Dr. Linda Park here. Today I'm going to talk about lightwire appliances. It's just another treatment modality that I use to help patients achieve their genetic potential. And as I explained before, I've been on a long journey of learning and growing and developing my thoughts and my treatment protocols to help patients. And it steered me to a group called AAGO out of California. It's the Academy of Airway and Nathologic Orthopedics. It's a big mouthful to say that we use lightwire appliances, very little fixed appliances. We don't use rapid palatal expansion. We use these lightwire appliances that are gentle and help to develop the cranium. And while you're doing that, you are expanding the airway and you're straightening teeth naturally. So that's my approach. It's more gentle and natural than the more traditional approaches are. The first appliance is the ALF appliance. This was developed by a dentist named Dr. Derek Nordstrom in conjunction with an osteopath who realized that, again, I keep going back to the cranium, but cranial strains and cranial dysfunction are what cause crooked teeth. Here's an example of a patient that I had that was probably 6 or 7, about 6 years old, as you can tell by the 6-year molars not being in yet. And you can see how narrow the arch is. These are her baby teeth, and almost all of her baby teeth are touching. Now, in ancient skulls, there is supposed to be a nickel width of room between every baby tooth, because hiding up in the bone is are these much larger teeth. So what we did for our patient here is we developed an ALF appliance, and it has an omega loop. It's made of yellow alloy, and that is a very springy and resilient wire, and it doesn't overcome the system, because when you push too hard, the system can fight back. And you're forcing the cranium and the palate into something that it's not really comfortable with. So this is gentle persuasion of the cranial bones by using the teeth. And we like to use the baby teeth, so we like to get started as young as possible, but we use the baby teeth as handles. And the expansion happens at this omega loop and at auxiliary loops. So just like in this patient here, we had a lot of space to gain, so I used 3 loops to develop her situation into this, where you can see how much more space she has in comparison. So this process takes about 9 months of development, and it's much slower than a rapid palatal expander, which is usually 4 to 6 weeks, turning of a key and then holding, and then eventually that comes out. And if you haven't addressed myofunctional needs of the patient by making sure the tongue is on the roof of the mouth to stabilize and hold what you've developed, then they're going to relapse. And relapse is a common thing in traditional orthodontics. So you can kind of see the difference in palate size, and the biggest difference is in the anterior, because the ALF opens up the premaxilla and makes room for teeth. It also develops the midpoint of the maxilla. That's where the bicuspids are going to come in, but it can also develop back by the molars as well. So again, it's a more body-friendly device that actually causes orthopedic expansion, and we do upper and lower jaws in the expansive process. Here's a lower jaw example that we used. You can see that this patient, this is how we started, and the wire you can see is much wider, and it fits in there, and it actually does create room on the lower jaw as well. The next appliance I'm going to talk about is the Broderson Crozat. This one is a little bit different. It's made of a different material. It's called Leone BioSteel, and while it's still flexible, it's a little bit less springy than the yellow alloy that I talked about with the ALF appliance. They both are cranially friendly appliances because they're lightwire, and lightwire is just kinder to the whole system. And again, it uses the teeth as handles to expand the cranium. So you can see some of the flex that this one has, but it looks different than the Alpha appliance. If I bring that one up here, you can see the difference between the two appliances. So this one is much springier than this one is. But the Broderson Crozat has something that works in the front of the mouth, as well as a power loop in the middle back here that can actually advance the premaxilla that I've talked about. So if we look at, it was actually for this patient who we took from this situation of a super narrow jaw, so narrow that his incisor was much further back than it should be, to, here's a better picture of it. This is the appliance on the model, and you can see that we took him from here to this situation. And you can, I don't know if you can tell in the picture, but the arch is much wider and more rounded. And one thing I like to do for fun and show the patient is that I can, if I put my thumb in here, there's not a lot of room for it. And as I move forward, we had done some development. There's a little more room for my thumb. And now my thumb is swimming in his palate. And that's great because that means his tongue has more room. And if we were to measure his arch, I measure intermolar width, and that's right in here. And a lot of times, this one is a little bit wider, but it can be in the low 30s. In this palate, he is in the 40 millimeter range. 40 millimeters is a happy home for the tongue. And when there's a happy home for the tongue, this is stable and can stay. So we use the Broderson Crozat, for, certain reasons, and it's more dentist directed. It can move segments a little differently than the ALF can. So there's benefit for either appliance in various situations and patient needs. The last point I want to make about these appliances is there's no key to turn, and so the patient's coming in about once every 6 weeks for me to activate the appliance. So I will activate the loops and the wire, and then because of the spring in the wire, it takes about 6 weeks for that to do its work. It's gentle and slow, and the patient is wearing these basically 24/7, and I don't have kids take them out to eat because they could lose them in their lunch napkin or lose them at the restaurant or whatever. So for kids, they stay in all the time. For adults, I let them take them out to eat and things like that. But these are dentist adjusted as compared to the rapid palatal expansion, which is a parent turning a key and then locking that after the 6 weeks of arch development. This is, again, about 9 months of arch development. And that means that the total time of active expansion is approximately 9 to 12 months. Varies from patient to patient and compliant to non-compliant, but typically we're seeing about 9 months to achieve the arch development that we're looking for the patient. And then I use these almost as retainers. The patient's used to them. As I said, the baby teeth are handles. I may choose, after I get to the expansion goal that I've set at the beginning, to put them in a myobrace or something to kind of hold them and round out the arches a little bit for us. Thank you so much for taking time to watch this video. I hope that you found it helpful, informative, and really expanded your ideas and opened your eyes to the different ways to treat a patient and solve some of these symptoms and root causes. If you did, hit the like button and subscribe for more great content.